Dr. Lin, ready?
Yeah. Okay. Dr. Sazi Kasim, you can start the introduction now.
Thank you very much, Professor Lin. And good afternoon, good morning, depending where you are, and welcome to the APSC Cloud Forum on Cardiovascular Disease series. Today, we shall be talking about dyslipidemia management across the total lifespan for atherosclerotic cardiovascular disease prevention. And we will be looking at it from an Asia-Pacific point of view. We have 6 fantastic speakers who will be talking to you for the next 2.5 hours, delivering 20-minute lectures with 5 minutes Q&A in between. As a preface, we as clinicians are often facing this dyslipidemia dilemma, and its management, mainly hypercholesterolemia, is a key strategy in the prevention of atherosclerotic cardiovascular disease, such as acute coronary syndrome, a stroke, and peripheral artery disease. For familial hypercholesterolemia, the threat of hypercholesterolemia itself can start as young as in utero, right up to being in adulthood and to the older age. How we as clinicians decide on medication therapy, lifestyle intervention, the usage of statins, PCSK9 inhibitor, etc., as well as newer drugs across the total human life will be the focus of our lecture this afternoon, this morning. We know that multiple clinical trial-based evidences are accumulating in primary and secondary prevention to try and control atherosclerotic cardiovascular events. Yet, we are still groping in the dark for special populations, such as young adults, adolescents, women of productive age, and the very elderly. So welcome again. My name is Sazli Kasim. I'm a cardiologist, professor and director of UiTM Teaching Hospital in Malaysia. I'm also a council member with the National Heart, as well as a fellow with the ESC. My co-chair this afternoon is Dr. Po Sun Huang, a professor and division chief from the Institute of Clinical Medicine, National Yang Ming Chiao Tung University from Taiwan, who will also be a speaker later on. We are very honored to have our first speaker for this morning, this afternoon. That is Dr. Purani Kanakraj from Thailand, who is an assistant professor and endocrinologist, and she is currently attached to the Department of Laboratory Medicine, Faculty of Medicine, Division of Endocrinology and Metabolism, Chulalongkorn University, Thailand. She will be lecturing us on dyslipidemia management for primary prevention of ASCVD, children and adolescents, the who, when, and the how. Dr. Purani, your mic is muted. Thank you.
Okay, thank you. Thank you very much for the kind introductions. I'm Dr. Purani Kanakraj from the Heart Association of Thailand, an endocrinologist, and I'm feel honored to be here in the webinar discussions today. So let's start with my talk. Okay. In children, and the who is at risk, the when to start screening or evaluations, and the how to manage. Atherosclerosis starts since childhood. There were some of contemporary studies that have evidence that the earliest stage of atherosclerosis that's already started at the first 2 decades of life. That was the fatty streaks. And here is the figure. You can see that the prevalence of fibrous plaque here with age, and the fibrous plaque in both of aorta and coronary arteries. Another results from the Bogalusa heart study, which is the long-term epidemiologic study of the cardiovascular risk factors that conduct the autopsy around in 200 young persons aged 2 to 39 years old who died from various causes, mostly from trauma. And see here in the table of the correlation coefficient of the antemortem risk factors, the LDL cholesterol showed the highest correlation coefficient and significantly correlated to the area of the fatty streaks in young adults. So we now know that atherosclerosis started since in childhood. So who is at risk? The risk categorized and grading like high risk group are among the homozygous FH, diabetes, end-stage renal disease, Kawasaki disease with persistent aneurysms. The moderate risk group are the children with severe obesity, heterozygous FH, hypertension, coarctation, and pre-dialysis, chronic kidney disease, and aortic stenosis patient. And the patient with at risk are in obesity child child with insulin resistance with comorbidities, or maybe even white coat hypertension and other cardiomyopathies, and children with the chronic disease like inflammatory conditions like SLE, HIV, or have the anomalies of coronary artery. Let's focus on the familial hypercholesterolemia, or FH, which is the most common inherited cardiovascular disease. The prevalence is around 1 in 250 in heterozygous FH and 1 in about 300,000 in homozygous FH, which the disease caused by the mutations in LDL receptor mediated pathway, like the LDL gene, ApoB gene, and PCSK9 gene. FH is significantly and substantially associated with the premature atherosclerosis and eventually give to the result of premature death. The clinical detection of FH in children and adolescents. For homozygous FH, the LDL level can reach high to around 400 to 500 milligrams per deciliters. And of course, the presence of cutaneous symptom, mostly the first presentation, if this presentation is very strongly suggestive of the disease. For heterozygous FH, we can detect these patients and patients with maybe siblings of the one who had FH before, or the ones who have family history of elevated LDL cholesterol or premature cardiovascular disease. The LDL level will be around 150 milligrams per deciliters. The presence of cutaneous or tendinous symptom may be present or maybe not. Here's the illustrations of the cutaneous symptom seen here, the yellowish plaque seen in the flexor areas of the wrist, of the knees, and on the ankles, or maybe seen in other regions having mechanical stress. So later, this is our patient who is homozygous FH since the age of 6 years old, and later in her adolescent, she still exhibits the symptoma and at the Achilles tendon and the tuberous symptoma, or the flat or elevated nodules over joints area like knees and elbows. Let's see the list of the primary dyslipidemia that's seen with symptom when we would like to give differential diagnosis. The familial hypercholesterolemia, the familial defective ApoB, both diseases are autosomal dominant and quite have very high level of LDL cholesterol and also very high risk of cardiovascular disease. The autosomal recessive hypercholesterolemia also exhibit symptom, moderate amount of LDL level, would have the abnormal LDL AP1 gene. The siderosterolemia has the quite moderate amount of LDL level increase, and maybe have other manifestation like hemolytic anemia, stomatocytosis, or thrombocytopenia. And the last one, the cerebral tendinous xanthomatosis. From the disease is from the names that have the abnormal of the cholesterol deficit in other tissues, because the abnormal in this gene causing the defect in enzymes in biosynthesis pathway. So the cholesterol will deficit in other tissue like the brain, causing the seizure, or like in the eyes causing cataract, in other tendon causing the xanthoma to be seen. And the lab result will see the normal or low level of LDL cholesterol. The classification of lipid level in children and adolescents. The LDL cholesterol that is high is about 130 milligrams per deciliters. And for triglyceride, if less than 10 years old, the number of more than 100 milligrams per deciliter is high, and about 130 milligrams per deciliters in age 10 to 20 years for triglyceride level. And when to start lipid screening? The benefit of lipid screening is, of course, to early prevent the development of risk factors, which is the primary prevention, and of course to recognize and manage the children with increased risk, like familial hypercholesterolemia patient or FH patient, which usually remain under diagnosis worldwide nowadays. To screen or not to screen is the debate in several academy and institutions, like listed in here. The reasons behind to not to screen is the insufficient evidence to recommend for or against the routine screening. And for the evidence for the screening is that usually mostly in the level of evidence grade B. There were two methods of screening. The selective screening would start screening since the age of 2 in children with risk, such as premature cardiovascular disease in family members, and parent with total cholesterol more than 240, or the children with risk like diabetes, hypertension, and severe obesity. And another method is universal screening. We'll start around 9 years old, and again, do the universal screening again after puberty at the age of 17. How to screen is you can do both of non-fasting or fasting lipid profile. And then how to manage the dyslipidemia in children and adolescents. We have to compose several strategies, like firstly, with dietary recommendations and encouragement of the physical activity in child, smoking avoidance, which include the secondhand smoker to be avoided, and to maintain healthy weight, and of course the medication. This is the algorithm that simplified from the pediatrics guideline that start with the fasting lipid profile twice time in average that resolves. If the LDL exceeds 250 or triglyceride exceeds 500, that is very high, just refer to the lipid specialist. And if the level is in between that, maybe we should look for the next step, that to exclude the secondary causes and to evaluate risk factors of that patient, like hypertension, renal disease, or obesity, and encourage a diet and lifestyle change around 6 months, and then repeat the lipid profile again. If the LDL level exceeds 190 milligram per deciliters, that is the threshold for start the statin. If the level in between 130 to 189, maybe consider statin treatment in patient with risk factor. For triglyceride level, if the level is higher than 200 milligram per deciliter, maybe you should start the fish oil medication and consult to the lipid specialist. And in between that, in 100 to 200 in the age of more than 10, or in the age of less than 10 years old, or 130 to 200 in the age of more than 10 years old, maybe should adapt the diet to give more of fish, dietary fish, and repeat the lab again in 6 months. And this slide will show the causes of secondary dyslipidemia in childhood and adolescence. Yeah. So the recommendation for the lab to evaluate is the thyroid status, the glucose, the creatinine, and liver, and of course the urinalysis studies. For the treatment targets based on cardiovascular risk factor stated in the circulation, we'll stratify patient in the risk group and give the threshold of the LDL cholesterol to be 130 to start management. And the guidelines state that we can initiate statin with the lifestyle change simultaneously if the LDL more than 130 in high-risk group patient, and the goal is to reach the lower of LDL than 100 milligram per deciliters. In moderate risk and at-risk group patients, if the LDL exceeds 160 milligram per deciliters, should start with the therapeutic lifestyle change first. And if the goal is not reached at the LDL level less than 130 milligram per deciliters, maybe consider the medications. The recommendations of dietary management will be the child one diet and child two diet protocols. And child one diet will focus on the total fat less than 25 to 30% of total calories, with a fat less than 10% and the cholesterol less than 300 milligram per deciliters. If the patient still cannot control their cholesterol level, then move to the next step of the child two diet that lessen the fat less than 7% and the cholesterol less than 200 milligram per day. And of course, avoid trans fat as much as possible, and encourage the high dietary fiber. For medications, statin actually have used for quite a while in children, and many large clinical trials has demonstrated efficacy and safety following 20 years of statin treatment with no significant side effects. And you can start statin measure the response and safety in 4 to 6 weeks. Before initiating statin, the guideline recommend to measure transaminase and creatine kinase before initiating statin, and alcohol should be counseled for blood control. Other add-on medications with statins like ezetimibe, PCSK9 inhibitor, biacid-sequestrant, lomitapide, there's the oral form, and evinacumab, the injection form, have been studied in patients mostly in FH patients with starting dose and maximum dose, and give add-on reductions of the LDL reduction. Then the other modalities of treatment is the LDL pheresis, a liver transplant with portal kilotron in rare cases. The role of genetic testing is benefit that will predict the responsiveness to treatment. And of course, if you cannot do the genetic testing, it's fine, because actually the intensity of treatment is guided by the LDL cholesterol level, not the genotype. For the role of cardiac imaging, only the homozygote FH testing since the diagnosis. For others, routine cardiac monitoring with imaging, vascular imaging is not needed. The last one that I would like to mention is the Lp(a), that is a useful marker that have increasing study that associate with the high-risk patient, and maybe the useful marker to identify the high-risk patient group. That's the last slide of my presentations today. But I would like to thank you to the Thai Heart Society of Thailand and Endocrine Society of Thailand that work together to put awareness of FH in Thai. We are the Thai FH network, but you can visit our website and our activities to raise awareness and do the.
Thank you very much, Dr. Purani. A very wholesome lecture, as you demonstrate quite clearly the clinical findings and also right up to the therapy. Maybe one question, especially for the clinicians out there, once you have a diagnosis and you are going to start on statin therapy, how do you do it? What type of statin do you use? What's your initial dose? How many days or weeks before you upgrade them? How do you motivate?
Yes, well, I would start statin since the age of 8 years old, and actually the most statin I choose is losuvastatin, as this is the very first statin type that study in children, and might start with the low dose like 5 milligrams, and maybe start with the alternate day, because the long half-life statin of the losuvastatin, and because some kids may have exhibit some side effect or like myopathy as well, but then if we start small and slow, they can tolerate that.
And
okay.
how do you convey to the kids on the need to take statin medication? These are
This is a very interesting question. Before start treatment, we have to assess for the contribution from the family members, from the parents, from assess their understanding of the disease. That have to be the long-term management if they're since they are FH, right? And of course, I would have to ask for help from their parents and to guide their children, because maybe the children at the very first visit, they will scare of us, of our white gown. They will not give us a trust. I think collaborative treatment with the parent will do a lot of help.
How frequent do you see them?
Actually, very few, because I will see these patients like after they come to the adult clinic, because I'm not the pediatricians, I'm the adult endocrinologist, but like because I do the study of FH, so I do collective some data of the homozygous FH, so I see that patient. But personally, I didn't start the medication myself, mostly with the pediatricians, and maybe I'll see afterwards they come to the adolescent and adult clinic. Yes.
And do you practice checking the bloods for evidence of myositis or abnormal liver function as they continue to take the statin therapy, or do we not bother?
If you mean if there are some transaminitis occur, right? Yeah. Of course, we will check for the transaminitis level, the AST and ALT level, and yeah, I once see the case from pediatricians sent to me that they have the transaminitis from the statin treatment. So, but when we look for at that time, they have drug interactions with the antibiotics that the patients was prescribed during that illness at that time, and have the drug interactions that give the AST and LT sky high, and then so we reevaluate and stop the medications for a while to wait for the AST to normalize, and then rechange other statin type, and then that child can go on another statin type, can tolerate the statin treatment. Yes.
Brilliant. Just out of interest, how many patients do you have in your study right now?
How many? About 200 to 300 patients.
Wow.
Yes.
That's very impressive.
Both include heterozygous as well, not all the homozygous.
Right. Okay.
Yes.
Thank you very much, Dr. Parania. I really enjoyed your talk. We shall move on to our speaker, Dr. Wang J. Lee. He is an associate professor from Seoul National University, Bunak in Korea. He is an interventional cardiologist who has been practicing more than 16 years, an active member of the Korean Society of Cardiology, and a graduate of Seoul National University Medical School in 2004. Dr. Wang Jae Lee will be talking to us on the dyslipidemia management for primary prevention of ASCVD in the young adults between 20 to 39 years of age. Again, who and when, and also how do we approach this particular topic?
Thank you, Chairman. So do you see my screen?
Yes.
Okay, thank you. So I'm Won Jae Lee from Seoul National Hospital, Korea. I'm an interventional cardiologist. So I'm going to be talking about primary prevention for 20 to 39 years of age. So there are actually dedicated guidelines for this age group. So it was a bit hard to find much literature, but I'll try my best to. So I'm going to talk about what are issues in these young adults 20 to 39 and what do current guidelines say. And I'd like to focus a little bit more on young adults with FH because this is a very important population. And I'm going to talk about a little bit of suggestion. So what are the issues? Let me start my talk with a case. So very young patient with dyslipidemia and smoking. So 35 years male came in with chest pain, with arrest, and luckily RSC in 4 minutes. ECG shows impaired STEMI. So we went on for a prior PCI, other risk factors like hypertension or diabetes. So if you look at the NGO, you can see that there's total occlusion in PDA, also PA branch, but it doesn't seem like thrombosis happened here. I think this is the plaque rupture happened here and the thrombus migrate down there. So we did a ballooning and some suctioning multiple times, and finally we could open the arteries, but you still see the very high risk plaque looking. I think LDL cholesterol is really a building block of atherosclerosis. Yes, coagulation or platelet or inflammation are all important factors to develop atherosclerosis, but I think LDL cholesterol is the main factor. And from the InterHeart-9 study, we know that not smoking or even above diabetes, hypertension, diabetes is one of the most critical modifier risk factors for acute MI. Meaning, if we control LDL, we can prevent a lot of acute MI. However, for young adults after an MI, statin is not indicated in a lot of times. So this is a young MI registry. It's not 2030, but this is a registry having relatively younger population. So in this registry, we spent first MI. If you look at, we applied 2013 ACC/AHC guideline, statin recommended in only 31% of population, and not recommended. And patient like this patient who only had a smoking, then he wouldn't have recommended statin, and 50% would not have been eligible for statin treatment. So this is a very big problem in this population. This is another registry called Duke Registry. This is also evaluated a patient with, there is a subgroup with 55 years of age. If we apply 2013 guideline, 56.7% are only eligible, meaning another 40% was not eligible for statin therapy, even though they experienced a QMI. 2018 guideline made some changes and have paid more attention to these young adults, but the reality was that only 46 are eligible for statin therapy, meaning another 50 were not eligible for statin use, for even they are at very high risk for developing this kind of disease. I think cholesterol. So we look at the RCTs, the relative risk reduction is about 22%, but with Mendelian analysis, we look at the genetic LDL score, it's actually more, it's very important. So let's assume if somebody has LDL cholesterol 125, if he just keep on that, but if we do some intervention, lower the LDL cholesterol, if we can get down to like more or less at 80, this patient might not get MI burden and the importance of early intervention. And one other issue that I would talk about is that in this young population not diagnosed, and in fact, in this young adult population, coronary heart disease is 11 times more compared to who does not have FH. So this is also a huge problem, and you can see that they're at very, very high risk. And also, FH diagnosis, median age is 47. So meaning most of the people in young adults, while they're having these kind of FH, they are not diagnosed. So this is also a big issue in this young adult population. So what do current guidelines say about this young adults? In fact, in 2018 ACC AHA guideline, actually at the very beginning, they mentioned about 20 to 30 in young adults as a top 10 take-home message. But this message only says an assessment of lifetime risk facilitates clinical patient risk discussion, not really mentioning how are we going to treat these patients. Quotes that was in the guideline mentioned about adults 20 to 39 here. So there was a mention in diabetes population. If the young adult has a diabetes, then moderate intensive statin can be in here and there saying there's limited information on ACVD rates and RCT regarding these populations. So there are some recommendations, but they're not really strong recommendation for use of drug therapy for this population. This is another section that's specifically talk about young adults. So you can see they say prevention of clinical ASCVD optimally begins early in life. However, given the lack of evidence, they don't strongly recommend the medication. And also says FH often goes undiagnosed. But if somebody has primary elevation of more than 190, they recommend medication. And the other one that's catching my eye was that they were recommending coronary altered calcium scores. So what's in the guideline currently? These are all, there are only 3 sections that talks about that apply to these young adults. So if somebody, young adult, has a long duration of diabetes, then statin can be recommended, but it's only 2B here. And look at here, if somebody has a premature history of ACVD family, or if they have more than 1/6 of LDL cholesterol, then statin therapy can be considered. And the other is if they have 190, over 190 cholesterol, then risk assessment, high intensity statin right away. But that's only sections that they mentioned about. There was a very recent guideline was there in 2021 with ADA, and this is also has this 2 lines here. For patient with diabetes, age of 20 to 39, with additional risk factor, it may be reasonable to initiate statin in addition to lifestyle. So, and I couldn't really find any quotes in the ESC guideline. So this is pretty much what we have for this young adult population. Let me switch here a little bit to FH. So in this population, FH are important but are not really found. So in fact, worldwide, what we found is about one out of 500, but in reality, what we think is that it's really 1 out of 200. So a lot of times we're missing FH diagnosis. So what happens is that if you look at here, in the age of 80, who are diagnosed FH, the number of men are very small, right, at earlier age. And in 2039, the prevalence are low because they are not detected. So that is also a huge problem. There was a statistics regarding our Asian population, and you get there, Japan, Taiwan, Hong Kong. Estimate diagnosis only still, this is very, very big problem in our Asian population. I think you all know about FH and progressive atherosclerosis. I'm going to just skip this slide. So we should use Simon Broom or the criteria, but a lot of cases in our clinical practice, we cannot reach with definite diagnosis and cannot really provide optimal treatment. So risk of CHD. So let's look at somebody who do not have FH. So if cumulative LDL cholesterol 600 milligram would be a threshold CHD, then this patient will have some event around 55. However, if this patient is homozygous, then very early on, and heterozygous around 30, and if they have more risk factor, if they're male, they smoke, have diabetes, then the threshold goes down, even in the 20 coronary heart disease. So lowering, detecting FH is very, very important to control the risk in this population. Again, this is the blues are patient who has LDL cholesterol less than 130, and these grays are patient who has cholesterol 190. So in older age, the difference is not that big. Still like more than 1.5%. But if you look at the very, very younger age, the risk, ACVD risk for adults with FH are significant. And in this younger population, it's more the population in this age group. So why important? Just knowing it's not, that's what we want, but we know that early initiation statin actually helps. So you get the graph. Parents with FH, even for pre-survival, dramatically decreases. However, if they were diagnosed early on, and also other agents, they have very, very less event and actually very comparable to general population as well. However, the other factor is that even though patient use statin, about only 20 or 30% of patients are actually achieving LDL cholesterol 100. If we apply 70, well, it would be far lower. So that's also a problem. Consider that 50% LDL cholesterol reduction, but still they are not reaching their target goal. So monotherapy alone, I think, will not do much for this FH patient. So in the past, ESC's guideline, we're talking about LDL cholesterol 100, and if they have more heterozygous or homozygous FH. However, in 2019, the guideline has heightened their bar. So if FH with ASCVD or with another minor risk factor, they put them in very high risk. And if they have just FH, then they're still at high risk. The recommendation was that very high risk, more than 55, and high risk is 70. So compared to a previous goal has been lowered for FH patient as well. And as you can see here, with class 1 indication, FH should be diagnosed using clinical criteria, and also familial cascade screening is recommended. And the more than 50% reduction and lower than 55 was recommended, and using PCSK9 is also strongly recommended in this population. What I found was that a lot of literature suggests that they were suggesting broader use of coronary artery calcium screening, because we all know that CC score actually are very independent from other risk factors and very useful for identifying and risk stratification of ASCVD. So they were suggesting using a CAC score, and we can really capture the risk, high risk population in these young adults. And most guidelines say about this young adults are 2B. So they were saying there should be a class of the guideline class of recommendation should be heightened risk for MI, and we should assess them with a high lifetime risk, and so that we can recommend statin more and more. And so it's editorial and published in JACC. So diagnostic risk assessment, they said, let's focus on risk factors, not just risk scores. And we should think about considering modifying risk factors for these young individuals. And if there are riskiness or present, let's go for more aggressive treatment. And also, and I think coronary calcium score can be a good tool. And also they were talking about lipo-Lp(a) as a progenitor risk factor as well. So let me continue on seeing the residual heavy plaque burden at proximal RCA. So what should I do? Because he was diagnosed with dyslipidemia before. However, he was still at 125 LDL cholesterol. So let's think about it. If we use milligram, but it's still get down only 6%, above 100 still. And I add ezetimibe, I might break down 20%, but still about 94. We are not seeing reaching the goal. So what I did was that I doubled statin, added a K9 inhibitor right after PCI, so that I could really break down LDL cholesterol, and I could see LDL 32 at the 1 month outpatient clinic visit. So this followed angio about 1 year later. So compare it, you see smoother contour, and you can also see from OCT that I don't really see much of a lipid core, and this fiber is capped, and I don't really see high features, so no need for stenting for this patient. And in fact, I've maintaining PCSK9 inhibitors for 3 years now, and he's about LDL cholesterol 22. He's not having any events. So my summary is that lifetime risk evaluation should be done with, and we should pay special attention to risk enhancers in addition to high LDL, like smoking and diabetes. And I suggest that we should screen for subclinical ASCVD. And I think using tools like coronary calcium score would be a very good choice. And again, FH should be taken very seriously as they have very high risk. And I suggest that we should have more aggressive approach, should be because lower is the better and earlier intervention matters. Thank you.
Thank you, Dr. Wonjay. Again, a very good set of lectures. It's very relevant, especially for our population in Southeast Asia. I see a lot of patients with young MIs. Our national statistics is about 5 to 7.5% below the age of 40, and we've been as young as 19 years old, and often associated with smoking, which is good, viable risk. In terms of the risk scores, you've mentioned that a lot of time they underestimate the risk of MIs. In your country, or where you are right now, which risk score do you use, and how do you find them? Are they applicable to your young cohorts?
So we're also using PCE equation. However, we actually use a little different. So we modified a little bit to Korean population because there was a discrepancy if you just PC the original to Korean population. So we modified it, but still for younger population, I think it's still underestimating. So so as a lot of some experts says, I think just using PC will not really do the job for us. You might need to think about new score. Or so you mentioned about smoking, right? So typical MI patient, in young MI patient I see are smokers. They don't have hypertension, diabetes, but they're smokers. And after PCI, we do the test, and they're found that they have high LDL cholesterol. So I see those really two are factors that are very taken more seriously in this population. So yes, that's what I experienced.
Yeah, I totally agree with you. Smoking and the presence of elevated LDL in the background, it just causes plaque rupture, very rampant. You also mentioned the use of coronary artery calcium scan in the young population. That's very interesting. I use it every so often. However, how do you monitor them? I mean, like we know that once you've started them on statin therapy, the calcification would increase.
Right.
It's also a cost for concern, right? When you cast them again, do you intensify the therapy because the calcium goes up after about 5-6 years or so? I mean, what do you do? What's your approach?
So the guideline really actually suggests us to use coronary calcium for the just first time. They don't really recommend it to repeat it because, as you mentioned, if you statin, definitely coronary score goes up, and there isn't much value for following up because we know once started, coronary calcium has started, it just go on and on and on. So since a lot of Koreans get health checkup, so actually in my clinic, not 20s, but people between 30 to 50, they get annual checkup, and these annual checkup tend to include coronary calcium score in many times, and they visit my clinic. So that's a routine pathway that I go through. So if I see those patients, if coronary calcium is elevated, regardless of score, I check LDL cholesterol, and if most of the time it's more than 130, even more than 100, I just recommend statin and just follow up.
Absolutely, I think that is the right way to do. Risk modifiers, Lp(a). Now it's going to get a lot more traction in the near future with the availability of therapy against it. Do you use it widely in your practice?
So we measure at least once. So most of my patients, especially my patient, we check at their discharge once. So, and also current guidelines is what's recommended at least one time in their lifetime. So we check just at least once. But what we found is that I know that Lp(a) elevation is quite common in Western population. I do not know the exact number, but around I think 30% having more than Lp(a) of 50 milligram. But we have done a little, screening study in our patient population. But I think the proportion of elevated Lp(a) is actually a little much lower. We felt that it's around 10%. Well, it's not like national registry data, but we've seen that in Asian population, well, the importance of Lp(a) cannot be ignored, right? It's very important, but the proportion of people having high Lp(a) seem to be much lower in Asian population, Korean population compared to Western people.
That's an interesting finding. Okay, Dr. Won-jae, thank you very much.
Thank you.
Enjoy your talk. Right. I must apologize to my co-chair, Professor Huang, because I'll be introducing him. He was meant to introduce Dr. Won-jae earlier on. Our next speaker, ladies and gentlemen, is Professor Po-Sun Huang, who will be lecturing on the prevention of ASCVD between the age of 40 to 75. Primary, talking about secondary prevention. Professor Huang is Professor and Division Chief from the Institute of Clinical Medicine, National Yang Ming Chiao Tung University from Taipei, Taiwan. He is also an internal physician. His research has been pretty much focused on endothelial dysfunction and atherosclerotic cardiovascular disease. So without much ado, I would like to introduce you, Professor Huang, for the next lecture. Professor.
Hi, thank you, Professor Kassim. Ladies and gentlemen, my dear colleagues, it's my great pleasure to present the latest 2022 Taiwan lipid guidelines for primary prevention on behalf of our society. I'm Dr. Huang from Taipei, Taiwan. The Taiwan Society of Lipids and Atherosclerosis, in association the major society in Taiwan, published the Taiwan lipid guideline for high-risk patients in 2017, led by our President Professor Yihen Li. The optimal lipid target and treatment strategies were recommended for high-risk patients, including those with coronary artery disease, PAD, diabetes, CKD, and familial hypercholesterolemia. In this guideline, we recommend that the LDL cholesterol should be lower than 100 in PAD, lower than 70 in stable CAD, ACS, and suggested LDL cholesterol lower than 55 milligram per deciliter in DM combined with ACS. The Taiwan lipid guideline for high-risk patients was modified in 2022. The modified LDL cholesterol target in high-risk population suggests lower LDL cholesterol target to 70 milligram per deciliter in PAD patients, and also in patients with ischemia stroke, TIA, and cerebral or carotid atherosclerotic stenosis. Today, our focus will be in Taiwan lipid guideline in prime prevention. So the outlines of my talk today include definition of prime prevention, SCAR prime prevention, the risk assessment, LDL cholesterol target, non-pharmacologic and pharmacologic therapies. The Taiwan Society of Lipid and Atherosclerosis, in association with the other 7 societies, developed this new lipid guideline, focusing on subjects without clinically significant SCAR since 2020. First of all, let's talk about the definition of prime prevention and how to define the SCAR. The clinically significant SCAR include coronary artery disease, such as angina with positive stress test, and all major coronary artery diameter stenosis more than 50% by imaging studies, acute coronary syndrome such as myocardial infarction and unstable angina, cerebral vascular disease such as TIA, ischemia stroke, carotid artery diameter stenosis more than 50% by imaging studies, PAD with major extremity artery diameter stenosis more than 50%, and evidence of atherosclerotic disease such as AAA by imaging studies. So the treatment algorithm of LDL cholesterol for SCAR prime prevention is shown in this slide. Subject without clinical evidence of SCAR was included in the prime prevention. Based on the above mentioned risk factor evaluation, the subject with prime prevention can be classified into the following risk categories. High-risk patients indicated subject with diabetes, chronic kidney disease, or LDL cholesterol higher than 190. In those without DM, CKD, or LDL cholesterol more than 190 milligram per deciliter, we suggest identify the number of risk factors of cardiovascular disease, including hypertension, aging, family history of cardiovascular disease, low level of HDL, smoking history, and metabolic syndrome. The SCAR prime prevention risk assessment in Taiwan, a point-based prediction model to predict the 10-year risk of cardiovascular disease, was developed from the Jinshan Community Cardiovascular Cohort Study in 1990. However, the definite cutoff point to define the high risk was not indicated. At current stage, using the numbers of risk factor is a more convenient way for risk stratification in Taiwan. So the SCAR 6 risk factor in Taiwan in our guideline would suggest the following. The first one is the hypertension, and the second one is the aging group. If the age higher than 45 years in men and or higher than 55 years in women, or have the menopausal women. The third point is the family history of premature CAD. The fourth is the low HDL levels. The fifth is smoking history, or the last point is the metabolic syndrome. Because the central obesity, prediabetes, and triglycerides are also considered to be as risk factor in some studies, so metabolic syndrome that includes all these items is regarded as a 6th independent risk factor in this new guideline. So the slide shows the use of the 6H as the familiar memory, the high BP, high age, history of CVD, low HDL, smoking, and high body weight. Since the SCAR is a major problem contributing to significant mortality in populations with DM and CKD, so these two groups of patients are considered at high risk, there's no doubt. But severe hypercholesterolemia, defined as having the LDL cholesterol higher than 190, carries a significantly high risk of SCAR and premature cardiovascular event, because the subject with LDL cholesterol higher than 190 is a very unique and high-risk group with a distinct long-term clinical outcomes. So those with LDL cholesterol higher than 190 is suggested to define as the high risk, and immediate lipid-lowering therapy is suggested. So in subjects without diabetes, CKD or LDL higher than 190, the risk of ASCA should be classified as minimal, low, or moderate risk according to the risk factors. So subjects with more than 2 risk factors are indicated as moderate risk, and those with 1 risk factors are indicated mild risk. Subjects without any cardiovascular risk factors are indicated minimal risk. So that's our the risk category. Then we will talk about the LDL cholesterol target. For subjects with diabetes, CKD, or LDL higher than 190, this guideline suggests that the LDL cholesterol level for initiation of therapy and treatment target is 100 milligram per deciliter. In subjects with more than 2 risk factors and LDL cholesterol higher than 115, non-pharmacologic therapy should be initiated, and the LDL cholesterol target is less than 115. In subjects with 1 risk factor and LDL cholesterol higher than 130, non-pharmacologic therapy should be initiated, and the LDL cholesterol target is less than 130. And in subject without any risk factor and LDL cholesterol higher than 160, non-pharmacologic therapy should be initiated, and the LDL target is suggested to be lower than 160. So the LDL cholesterol levels for initiation of therapy and treatment target in subject with more than 2 risk factor is 115 milligram per deciliter based on the expert consensus. And this recommended LDL cholesterol level is close to the 2019 ESC lipid guidelines, suggested that the LDL cholesterol level less than 116 milligram per deciliter in the low-risk individuals. And this recommended LDL cholesterol target of 115 is lower than that in Japanese and Korean lipid guidelines, where the LDL cholesterol target is less than 140 milligram per deciliter for moderate risk in Japan. And this is Korean lipid guideline, they suggest that lower than 130 milligram per deciliter than in patients with more than 2 major risk factors. So let's talk about the non-pharmacologic therapy in 2022 Taiwan lipid guideline for prime prevention. So several observations and the randomized clinical studies have demonstrated association between a low risk of ASCA and healthy dietary patterns, such as Mediterranean diet, DASH diet, and healthy Taiwanese food diet. So in this guideline, we suggest that the population should take more the Mediterranean diet, DASH diet to reduce the cardiovascular risk. About the exercise, all adults are encouraged to engage in at least 150 minutes per week of accumulated moderate intensity aerobic physical activity, or 75 minutes per week of vigorous intensity aerobic physical activity to lower the ASCA risk. Even exercise with a short duration of 5 to 10 minutes with 1 to 2 minutes interruption is also to be beneficial as the longer ones. About the cigarette smoking, cessation of cigarette smoking is highly recommended to reduce the overall cardiovascular risk. And people who do not have a habit of alcohol consumption should avoid starting drinking for any reason. And alcohol consumption should be limited to less than 100 grams per week in men and less than 50 grams per week in women without the aldehyde 2 dysfunctional allele. The healthy lifestyle, diet rich in the plant-based food source of omega-3 fatty acid, fish, nuts, and legumes, lean animal protein, which can maintain healthy body weight, is highly suggested. And also minimize the intake of trans and saturated fat, processed meat, and refined carbohydrate is recommended. So the healthy lifestyle recommendation, regular physical exercise is highly recommended, and reduction of alcohol intake and cessation of smoking are suggested. So let's talk about the pharmacologic therapy in lipid guideline for prime prevention in Taiwan. The recommendation about the drug therapy starting the first-line therapy and the benefit of starting for prime prevention of ASCA is well established. So it is reasonable to initiate moderate intense starting first and titrate to high intense starting if the treatment goal is not reached. So for prime prevention in subject without clinically significant ASCA, risk stratification is necessary to determine the lipid lowering strategy. So for prime prevention, subject with diabetes, CKD, or LDL cholesterol higher than 190 are at high risk of ASCA. And the suggestion is that the immediate lipid lowering therapy is necessary. In subject without diabetes, CKD, or LDL higher than 190, the risk of ASCA should be classified as minimal, low, or moderate risk according to the number of risk factors. So the intensity of starting is divided into 3 categories. High intensity starting, the dose could reduce the LDL cholesterol by greater than or equal to 50%, moderate intense statin, the dose could reduce the LDL cholesterol by 30 to 49%. And the low intensity statin, the dose could reduce LDL by less than 30%. So in subject with diabetes, CKD, LDL higher than 190, immediate lipid lowering therapy should be started, and the LDL target is less than 100 mg. In this guideline, we suggest that in patients with LDL higher than 190, moderate to high intensity statins combined with ezetimibe is recommended. And in subject with more than 2 risk factors and LDL cholesterol higher than 150 mg per deciliter, non-pharmacologic therapy should be initiated, and the LDL cholesterol target is less than 115 mg per deciliter. And if the treatment target is not met after 3 months of non-pharmacologic therapy, moderate intense statin should be considered. So in subject with 1 risk factor and LDL cholesterol concentration is higher than 130, a non-pharmacologic therapy should be suggested, and the LDL cholesterol target is less than 130 mg per deciliter. And in subject with 1 or 0 risk factors, if the LDL target is higher than 160 and not achieved after 3 months of non-pharmacologic therapy, moderate intensity statin should be considered after shared decision making. About the ezetimibe, ezetimibe is a cholesterol absorption inhibitor that blocks dietary and biliary cholesterol absorption at the brush border of the intestine. And the efficacy of ezetimibe in combination with statin for prevention of ASCA has been well established in patients with CKD or ACS in large-scale studies. So ezetimibe may be used in combination with statin in patients with prime prevention who could not reach the LDL cholesterol target with statin alone. And ezetimibe may be used as monotherapy in patients with prime prevention who cannot tolerate the statin. About the PCSK9 inhibitors, PCSK9 inhibitors bind to LDL receptor on the surface of hepatocyte, leading to degradation of the receptors and decreasing the reuse of LDL cholesterol receptor. So antibodies of PCSK9 interface is binding with the LDL cholesterol receptor, resulting in higher hepatic LDL receptor expression and lower plasma LDL cholesterol levels. So PCSK9 inhibitors can be considered for prime prevention in patients with high risk who cannot achieve LDL cholesterol target with high intensity or maximal tolerated statins combined with ezetimibe. Other lipid target and residual risk recommendations about the non-HDL cholesterol and ApoB can be considered to predict the risk of ASCA, especially for people with high TG, more than 150 mg per deciliter, diabetes, obesity, or metabolic syndrome. In 2019 ESC guideline, the ApoB is recommended to be less than 65, 80, and 100 mg per deciliter for very high, or moderate risk people, respectively. However, since the ApoB cannot be measured in most hospitals or clinics and rarely used in clinical practice in Taiwan, no specific target for ApoB is recommended in this guideline. About the non-HDL cholesterol, is suggested to be used as the secondary target, and the target of non-HDL is 30 mg per deciliter above the recommended LDL cholesterol targets. The TG, unlike the great success of LDL cholesterol lowering agent in preventing ASCA, so almost all TG lowering agents failed to improve cardiovascular outcome under starting therapy in the clinical trials. The reduced it evaluated the efficacy of purified high-dose EPA. After a median of 5 years follow-up, the icosapent HCl group had 25% lower risk of cardiovascular event compared with the placebo group. So in this guideline, high-dose EPA therapy can be considered for patients with ASCA or with diabetes, more than 1 risk factor who are already on maximal tolerated starting therapy with high TG level, more than 150 mg per deciliter, and the level of evidence is 2A. So this is my take-home message. Ladies and gentlemen, my lecture suggests that the ASCA risk assessment for non-SCVD people in Taiwan prime prevention guideline. So the DM, CKD, and LDL cholesterol level more than 190, we suggest that this group is a high-risk group, and their LDL cholesterol target should be lower than 100 mg per deciliter. Moderate to high intense statins is considered in this population. And then we should calculate the 6 risk factor if they the subject don't have the diabetes CKD or LDL higher than 190. The 6 risk factors, we have formula memory 6H. If subjects have 2 or more risk factors, they are divided into the moderate risk. If a subject with only 1 risk factor, they are indicated as low risk. And a subject without any cardiovascular risk factor, they are suggested as the minimal risk. We have lipid cholesterol targets separately. So thank you so much for your attention.
Thank you, Prof. Wang. That was a very comprehensive lecture again. The development and utilization of the ACVD for primary population, how did that came about? What was the process and what was the rationale to adopt that particular risk score?
You mean adopt how to define the CVD risk?
I mean, how did your team decided to utilize that particular risk score for the Taiwan population?
In Taiwan, the major problem limitation is that we lack of the scoring system to just calculate the 10 years risk of CVD. So we adjust the number of risk factors to define the patients into the high, moderate, or low risk. So first of all, we divided the high risk as the CKD, diabetes, and LDL cholesterol higher than 190. That's the major part of the high risk for primary prevention. If subject without the diabetes, CKD, or LDL higher than 190, then we will calculate the numbers of risk factors. So this experience is fit to our clinical practice in Taiwan. Our Taiwan insurance also use the risk factor numbers to decide how LDL target that we should provide the lipid lowering agent.
Very interesting. And has it been validated prospectively?
Yes. Some group already use the numbers of risk factor to calculate the 10 years of cardiovascular risk. But they published the small clinical studies in journals. So the point is that we cannot, we don't have the very well accepted or convinced evidence to use the scoring system in Taiwan.
I think that's a really important message to send across, because there's a lot of risk scores being developed in different cohorts, being applied to different countries and different cohorts, which may not be appropriate. So I am in awe of your work of coming up with your own native risk score. That's a very good point.
Yeah.
From a clinical point of view, you've mentioned a high risk group. What are your thoughts regarding CKD patients on dialysis? The evidence shows that they should be off statin therapy. Do you approach them differently?
Yes, in the primary prevention guideline, we just suggest a CKD not without dialysis that should aggressive and early immediate to use the lipid lowering agent. But patients with end-stage renal disease with hemodialysis, this group, we suggest that if they already keep on the starting therapy, we don't suggest they should withdraw the starting therapy if they put current stents in this high-risk group. But if end-stage renal disease patients with hemodialysis for many years, and then they put the current stent or has acute coronary syndrome, this group that we don't have definite consensus about should we use the starting or lipid lowering agent in this group. Some nephrologists just suggest that we don't need to use the statins in this end-stage renal disease with HD group because the clinical evidence showed that no benefit in this high group. But for cardiologists, maybe interventionists, that we still suggest that we may use the statins in this group.
Yeah, we're very concerned about patients coming back to us, so I don't think it's a good approach. Okay, Professor Huang, I think I will let you take over the show right now.
Thank you.
Apologies again for jumping the gun for the second speaker. Please carry on.
Okay, so now our next speaker is Professor Adu M. Shahab, a professor of cardiology, who is the Assistant Dean of Medical Education, Chairman of Cardiology Fellowship, Arab Broad Council, Chief Editor of NEMJ, Department of Internal Medicine, Faculty of Medicine, Health Science, United Arab Emirates University, UAE. So Dr. Shenham will now provide our next talk. The topic is the dyslipidemia management for primary prevention of ASCA in reproductive years. So let's welcome Professor M. Barbie, please. Yeah, we see your slide.
It's recorded actually. So thank you very much. I think the presentation.
Good morning, thank you very much for the invitation. I'll be discussing with you secondary prevention of ASCVD, focusing on dyslipidemia at range age of 40 to 75, and these are my disclosure. Well established that dyslipidemia play a major role in cardiovascular outcome based on a trial, which is a randomized clinical trial compared to placebo, and reduce LDL, reduce the events, cardiovascular events. The importance of that starts based on the level of the LDL when we start and the time we reduce the LDL. So the more we exposure to high LDL, the longer time, the worse the plaque, the worse the outcome. And this is based on the studies well established. So that's why it's important when we manage patient with the dyslipidemia, especially the secondary one, is patient to be on this medication for life. So to get the benefit, and this benefit relatives and absolute will be sustained. So LDL level time equal plaque reduction. One of the best randomized clinical trial has been in the field of dyslipidemia, no comparison. These are the medication, established medication lowering lipid therapies, and there are some investigation, one coming. And of course, a statin, which has been available for a long time, well established, many years of trials with minimal side effects. Then we get a great reduction of the LDL, those who are responder. And if you add ezetimibe, of course, you get 10 to 20% reduction. Then if add PCSK9 or the new ones coming, then you get even up to 85 reduction, as you can see here. We have guidelines, of course, will be based on this randomized clinical trial to tell us, to guide us how to use this medication, and based on their evaluation, based off the risk factors, based off the, then if we are in the gray zone, we have something called ACVD risk enhancer. And this is another way of illustrating that. So patients coming to us with dyslipidemia, we do a risk assessment with life modification, very important. That's diet and physical activity. We discuss with the patient the side effects and the benefits of the medication, the cost. And of course, this is shared decision at the end of the day for medication to continue. These are some risk score we use to evaluate the total risk assessment of the patient for cardiovascular event. Of course, when we use medication, and this is important to be discussed, that the patients might have side effects, accuracy of quantifying risk factors, of course, based on the which one is suitable for your region. Of course, again, based on life expectancy of the patient, benefit patient might get from this, then interpreting the evidence in an appropriate way. Secondary prevention, which is our focus today, these are the age we are interested in, less than 75 years, and those, of course, with a high, these need, all of them need high intensity therapy, which I'm going to show you because they are already established. But what's the threshold and what's the goal will be based, of course, every time we're refining that based on the evidence comes. So if you can compare 18 to 2019, European is adding, two together. And even now, we're going to show you a graph. This one will show you even you can go lower up to 1 millimole, which is 40 milligram per deciliter for those with multiple events. So again, when it comes to managing patient with ACVD, is lifestyle modification is important. Risk assessment is important. Knowing the goal for the LDL is highly important, of course, and need to reevaluate these patients to know where we are aiming and where we're going. So it'll be a shared decision. Illustration came some cases to make life easier and understandable. So as a 71 years old patient with multiple risk factors, you can see here already on a statin, had MI in the past, and you can see the LDL is not in target after 3 months. So this patients, you need to add another medication, which will here is to be if maybe ezetimibe, and more enforcement of, or you can even increase this one, make it 40 plus ezetimibe for achievement of the goal, which is less than 55. And another lady of 62-year-old, non-STEMI, PCI in the past, and multiple risk factors, which is very common. Patient adherent to the lifestyle, everything, but not tolerating ezetimibe. This happens, after some time, patient not able to take the medication, and you find yourself LDL not in target, and not in the goal. So this patient, you need to think again, reinforce the lifestyle, reinforce the patient done the best of they can, but sometimes you make sure the patient adherent. That's very, because that's what we forget. Another example here, patient already on 2 medication, which is ezetimibe and the high intensity statin, but not reaching the goal. It's another lady, the same. So these patients who are, at very high LDL, despite of the optimal combination, need to think about here PCSK9, which is well established from 2 major randomized clinical trial we have available, and we have the third one, which is another one which work in inclisiran, which work at the gene level, at cellular level. You on less frequency, you give medication which make again life easier. Let's go to the think about the patient here of presenting again is 56, 3 months of follow-up to your clinic, and major risk factors already on combination, and you can see the LDL is far away from the goal. So you think about yourself, is this patient taking the medication? Because not because you are giving the medication, you're certain patient, taking it. But so that's very important. If patient don't take the medication, of course, it will not work. So that's well established. That's a big challenge. Challenge for us. Challenge for the patients. We know from the trials and registries that the statin usage is fine, but high intensity statin has not been that good from many registries, and that's why we do not reaching the goal. And of course, there is a ezetimibe and PCSK9, which is very important when you find yourself the cases I've just shown you. So these are challenges for us. So unless we are, intensify our therapy, discuss with the patient about the goal and the importance of the adherence to the medication, we will remain, our patient remain out of the goal, and that's the major problem, and that's why patient having the events continues. So we know from the already this is discussed, these are the medication available, but only work when we use them. So just in summary, so the ages should not be a major limitation for management of the dyslipidemia, should be the same. As I've showed you the cases here, we all try to get them to the goal, which is through the, again, going through the algorithm, evaluation of patient risk, lifestyle, medication combination, ideally to start with, and reevaluate the patient if they are not in target, then use the the more important medication like PCSK9, which work on even LPA, as we know if the LDL is high, or LPA if it's high. So thank you very much for this opportunity, and looking forward to the discussion.
Okay, thank you, Dr. Abdullah Shahab. So thank you so much for your excellent lecture. And from your talk, I want to talk about the how to use the image study. For example, the carotid artery IMT measurement or coronary artery calcification. Do you suggest that we routine use the image study to divide the high risk patient or non-high risk patients?
Thank you very much for the opportunity again. I mean, because the title was focusing on ACVD, secondary prevention. So this patient already, you don't need any enhancement. You don't need anything else to guide you. Already patient established cardiovascular disease, either had MI or stroke. So here is the goal is very clear. And I think you should just try to use all the weapons you have to get to the goal with, of course, patient adherence to the medication and lifestyle.
Yes. Okay. Also about the very special population is the patients with TIA or cerebral vascular disease or previous stroke history. Do you think that the LDL cholesterol target should lower than 100 milligram per deciliter or even lower than 70 milligram per deciliter? How about your opinion?
If I speak about the patients we see in this part, we did lots of their histories, and an average when they have their MI actually around 80, which is surprising. And if you just base to go below 70, that's not good. You need to go at least more than 50%, which speaking about 40 and less. So really, it depends on what part of the world you're working at, and you need to look at that. Although the guidelines is there, but you need to modify it to your region.
Okay, thank you. So another point that we want to discuss is that patients